Thank you, and thank you to SAGES and the ASGE and to our moderators for this exciting joint symposia. And the given title was Should We Resect or Ablate Barrett's Dysplasia? But I'm going to spend the next few minutes talking about how we should be considering both to resect and ablate Barrett's dysplasia. Here are my relevant disclosures. So as we know, Barrett's is a complication of chronic reflux disease, and it is a known risk factor for esophageal adenocarcinoma. And unfortunately, esophageal adenocarcinoma has been steadily rising in both incidence and mortality over the past several decades. As we know, it's the replacement of the esophageal squamous lining by specialized intestinal metaplasia, and screening is recommended for those patients with multiple risk factors for esophageal adenocarcinoma as listed here. Traditionally, screening is done with endoscopy, but we also have novel, new, non-endoscopic screening devices and assays now available. The diagnosis is made by two parts: both the endoscopic appearance with salmon-colored mucosa in the tubular esophagus of at least 1 centimeter, and the histologic criteria, which is columnar-lined epithelium with the presence of goblet cells. For those patients who are diagnosed with Barrett's without dysplasia, we can perform surveillance every 3 to 5 years with something of with biopsy protocol like the Seattle biopsy protocol, which is to biopsy all visible lesions and then to perform random 4-quadrant biopsies every 1 to 2 centimeters, specifically every 1 centimeter if there's a previous history of dysplasia. Screening and surveillance have gaps in them, and it really is important that we do a high-quality endoscopic examination, and that's to identify the 5 L's, as I like to call them, looking at the landmarks, measuring with a validated tool like the PROG classification for the length, looking carefully for subtle lesions, and identifying those lesions, documenting them, and targeting them with either biopsy or endoscopic mucosal resection if that's your practice, and then also performing biopsies at multiple levels with something like the Seattle protocol. When patients are diagnosed with dysplasia, unfortunately, we have a lot of inter-observer variability among pathologists in the diagnosis of dysplasia in Barrett's esophagus. This is likely due to the large amount of inflammation, often due to the chronic reflux that we find in the esophagus, and dysplasia is often overcalled. There is less inter-observer variability among pathologists, and so therefore, before any resection or ablation, it's important to confirm dysplasia with an expert GI pathologist. In terms of defining who may benefit from endoscopic therapy, we can look at the risk of progression to cancer. High-grade dysplasia is the best marker that we have to identify who may go on to esophageal cancer, with an annual cancer incidence of 6 to 12% per person per year. In terms of overall low-grade dysplasia patients, they harbor a risk of progression of 0.5 to 0.6, which is often quoted, but this likely represents a heterogeneous group of patients. And those patients with no dysplasia have a 0.3% per patient per year risk or less, which supports a surveillance strategy in these patients. It's also important to recognize the risk of prevalent cancer. In high-grade dysplasia, we see that there is a risk of 40% of prevalent cancer in these patients. This is often intramucosal cancer, which can be endoscopically treated, and therefore the approach for these patients is similar. In terms of identifying the proper diagnosis, it's important to perform endoscopic resection for any mucosal irregularity in the setting of dysplasia. EMR is more accurate than biopsies, and it can change the diagnosis in over half the time, as we've shown at our experience in University of Chicago when I trained there. There's less inter-observer variability among pathologists with a diagnosis made by EMR. While endoscopic ultrasound is appropriate for nodal staging and deep T staging, it's inadequate for early T staging. In order to identify who may require surgery or systemic therapy versus endoscopic treatments, we can look at the risk of lymph node metastasis in these superficial cancers and tease that apart more. T1B lesions or submucosal carcinoma harbor a risk of lymph node metastasis of greater than 20%, and therefore they may require surgery. However, those patients with T1A or intramucosal carcinoma have a minimal nodal metastasis risk of 2% or less, and therefore they may benefit from endoscopic therapy, especially as we juxtapose that risk with the risks of esophagectomy in terms of mortality and morbidity. So when we perform endoscopic therapy, our goal is total Barrett's eradication. It's not only to remove the visible lesion, but it's also to treat the rest of the at-risk epithelium to address any metachronous or synchronous lesions. In terms of endoscopic mucosal resection, we can use a widely available technique, which is the band-assisted ligation technique. Here we can see in this gastroesophageal junction, we can identify any visible lesions, which we can see by white light. And we can appreciate there's a lesion that extends from 12 o'clock to 4 o'clock on white light at this gastroesophageal junction. Some of the features can be more easily appreciated under enhanced endoscopic imaging, which is commonly available with virtual chromoendoscopy, and in this case, this is narrowband imaging with near focus, which has a magnification feature. And we can appreciate irregular mucosal patterns as well as irregular vascular patterns that extend from that 4 o'clock area up to the 12 o'clock area. Also, if we look carefully in the area proximal to the Z line, we can also see some discoloration that makes it concerning for subsquamous extension. With band ligation EMR, we can use suction to draw the mucosa up away from the muscle, deploy a band just similar to variceal band ligation, and then use snare cautery to resect that newly created pseudopolyp. We can also do this subsequently in different areas to do piecemeal resection technique to be able to resect a wider area. This area was resected in a total of 5 pieces and the histologic specimen demonstrated intramucosal carcinoma with muscularis mucosal invasion. The negative margins that are relevant are the deep margin and piecemeal EMR technique, and in this case, the deep margins were negative. The lateral margins and piecemeal may be positive. The complete endoscopic mucosal resection technique is a way to address the entire Barrett's epithelium. And in a meta-analysis, we can see the eradication of neoplasia was demonstrated to be 96%. However, the complication rates include over a third of the patients had strictures as well as a 2% perforation rate. We have other modalities which are non-tissue acquiring, such as radiofrequency ablation, and these can be found in different footprints. We can see a circumferential balloon technique, which can treat 4 centimeters of the circumferential esophagus at a time. We can see focal devices, such as the over-the-scope technique, as well as channel devices that go through the working channel of the scope and are able to treat smaller focal areas in smaller footprints. A landmark AIM dysplasia trial demonstrated that 95% of patients had complete eradication of dysplasia at 2 years. However, it's important to recognize that dysplasia can recur, and this occurred in 17% of that cohort. Perhaps the best is to take the best of both worlds and to resect with EMR and then perform radiofrequency ablation for the rest of the lining. And this indeed gives us comparable rates of endoscopic eradication of neoplasia with a much more favorable complication profile. And this is probably our standard approach for patients with high-grade dysplasia and intramucosal carcinoma. We can use other ablation techniques, and these include the cryotherapy. There's the cryospray technique, which uses liquid nitrogen delivered through a spray catheter alongside a decompression tube that's placed in the esophagus and then the stomach. And the tissue is frozen upon contact, and then the cells actually die during the thawing process. We can also do cryoballoon. There is a focal cryoballoon device that can actually target areas along the axial length of a balloon catheter, as well as rotationally along the circumference of the esophagus, and can deliver a focal ice patch. Coming out this month is also a 180-degree spray catheter that the diffuser actually moves consistently across the length of the balloon to deliver the nitrous oxide, in this case, to the hemicircumference of the esophagus, allowing for basically a more consistent delivery of the cryogen. We also have hybrid APC, which is a technique in which we can lift the mucosa off the muscle layer using a submucosal cushion, as in this case using methylene blue and saline mixture, and that protects the muscle. And then we can use higher doses of energy with argon plasma coagulation to essentially burn the superficial layer of the muscle and ablate the tissue in the esophagus that way. On the other end of the spectrum, we can push the boundaries of Barrett's endotherapy with looking at submucosal cancer. I did mention high rates of lymph node metastasis, but this can be further differentiated by looking at the depth of submucosa. SM1 lesions harbor a much lower risk of lymph node metastasis risk, on the order of 6%, compared to the greater of 20% for SM2 and SM3 lesions. And we can identify a low-risk submucosal cohort of SM1 lesions less than 2 centimeters with well or moderate differentiation and no evidence of lymphovascular invasion. And treating these patients endoscopically has been supported by the German experience as well as the Netherlands experience. Endoscopic submucosal dissection is a topic that we're going to hear more about during this session. It's indicated for most cases of squamous neoplasia in the esophagus and can be used for select cases of Barrett's neoplasia. In a systematic review, we can see that ESD does offer lower recurrence rate than EMR, and they have comparable complication rates. Overall, generally, it's thought that EMR, whether it be focal or wide field EMR, is not inferior to ESD in most cases of Barrett's with high-grade dysplasia or intramucosal carcinoma. But ESD probably should be considered in select cases, and this could be, again, in all cases of squamous cell neoplasia, and then also in cases of large or bulky lesions, areas when we're concerned about submucosal invasion, or areas that are non-lifting, likely in previous therapy. Here is a case where we have a gentleman who had reflux, hiatal hernia, and Barrett's esophagus, and he was found to have low-grade dysplasia on a surveillance examination. And we can appreciate by this endoscopic examination that he has a medium-sized hiatal hernia and a Barrett segment that we would classify as a C6 M8 by Prague classification in terms of talking about the length. As we look on this, we can appreciate 2 lesions. One we can see on white light around 3 o'clock here. And the insufflation and deflation during the endoscopic examination really helps us appreciate the abnormal contour of that wall with it, so we can see that lesion a little bit better. We can also appreciate an other lesion at the very proximal segment. We'll go back to that. Again, here we see under narrowband imaging with near focus some irregular mucosal patterns as seen in this lesion. And that lesion up top at that proximal segment, we can appreciate a little bit of friability by white light. And we can appreciate under narrowband imaging, again, this distorted mucosal pattern and irregular vascular pattern in this area. So for this lesion, the first one I removed with a piecemeal EMR technique, and it demonstrated intramucosal cancer. So the patient was referred with low-grade dysplasia with biopsies. If we had pulled out the ablation catheter right then and there, we would have undertreated that patient. So again, EMR for all visible lesions. We found cancer in this case. The other one, I wasn't quite as certain. I biopsied the first time, and lo and behold, the biopsies came back suspicious for invasive cancer. So when I brought the patient back, I ended up doing an ESD and found intramucosal carcinoma with muscularis mucosa invasion. So at this point in time, we did offer the patient continuous endoscopic therapy, but in part of the counseling process, we also had a consultation with surgery to discuss esophagectomy, so that way the patient could appreciate all the options available to him. He did continue with endoscopic eradication therapy, had multiple sessions of ablation, including multiple sessions of RFA and a session or 2 of hybrid APC, and is currently in complete remission of intestinal metaplasia and is currently in surveillance. So we can appreciate that we can use endoscopic eradication therapy for patients with high-grade dysplasia and intramucosal carcinoma, select patients with low-grade dysplasia, specifically confirmed low-grade dysplasia, and select patients with submucosal disease, SM1, in that low-risk cohort. When we talk about endoscopic eradication therapy, it's not just about resection versus ablation, but I think it's really important to understand, do you need a tissue-acquiring modality, or can you do with a non-tissue acquiring modality? And recognize that tissue acquiring can be done endoscopically with EMR or ESD, but it also may require surgery in some cases with esophagectomy. And our non-tissue acquiring modalities can include, as I mentioned, radiofrequency ablation, cryotherapy, and hybrid APC. I think it's important to have more than just one tool in your toolbox. I also appreciate that a lot of our algorithms talk about the diagnosis as if we know that from the beginning, but sometimes we don't always know exactly what the diagnosis is. And so I think it's important to really look at lesions. And when you encounter a suspicious lesion, you need to resect it. And we can resect most visible lesions with EMR, but in certain cases, as I mentioned earlier, we might want to do ESD for large, bulky lesions or concern for invasive cancer, or especially in those non-lifting lesions. And then the rest of the segment can be treated with ablation. If we find high-risk features or evidence of lymph node metastasis, then those patients would require esophagectomy. And submucosal disease is probably a case-by-case basis. Decision-making takes into account patient factors, disease factors, procedure factors, and expertise, and vary from location and doctor, but should be part of the counseling in your patient. In conclusion, the risk of progression to cancer, the risk of prevalent cancer, and the risk of lymph node metastasis defines the appropriateness of endoscopic therapy. All visible lesions and mucosal irregularities in the setting of Barrett's neoplasia should be addressed with endoscopic resection for an accurate histopathologic diagnosis. EMR should be a part of any Barrett's endotherapy program. ESD may be required for select cases, and ablation is a non-tissue acquiring modality that can treat the rest of the at-risk epithelium. In terms of the patient characteristics, disease characteristics, and available expertise, all of this should be part of individual decision-making with your patient. Thank you very much. And April is Esophageal Cancer Awareness Month, so just putting that plug in for that at the, thank you.